Top Med Talk.
Well, hello and welcome to Top Med Talk. I am your host, Desiree Chappell, and I'm joined by the fabulous Monty Mythen in London, England. Monty, how are you?
I'm not bad. There's a bit of strange stuff going on around here that I'll share with you in a moment, but personally, I'm doing okay.
Good. It's nice and hot there. It's summertime over in London.
It has. We've had our annual heat wave, which lasts about 3 or 4 days. And, you know, we're British, so we complain about the weather no matter what it's like, apart from the very, very occasional day. That's a fair point. Recently, it's just been too hot.
Yeah, that's right.
Yes. And it's more the sweatiness, because we don't really have, apart from sort of office buildings, we don't do aircon at home very much. We're trying to stop people, you know, having aircon as the solution to everything, because we're, you know, most of the year here we don't need it. And, you know.
What did you tell me the other day about how hot it was there? And you guys were stressing about it? 88?
Yeah, no, we got to 90. Yeah, over 90. Yeah, we broke some records by UK standards, but we didn't manage 100% humidity, but we got close.
Yeah, that's a mess. Well, hopefully it's going to be nicer going out. We're almost to the end of August and getting into fall, so hopefully it's going to be nice weather.
Well, the weather's the least of our problems. I mean, because COVID-19 from the hospital basis at the moment is pretty quiet in the UK. Yeah. Touch wood, you know, at University College London hospitals, we're down close to no patients, and we're starting to reboot all the other services. We're getting ready for the winter. But the two sad things this week are, one is the exam results have come out for the sort of graduating students in the UK. And it's just been miserable from the point of view of people having to sort of best guess results and, you know, the unfairness that goes with that. So that's a real downer when people are trying to celebrate relative lack of COVID-19 at the moment. And the other thing is people have gone away on vacation to say, well, you know, I've worked really hard through the peak of COVID-19. I need a few weeks off, and they're reclosing the sort of borders. So they just put a quarantine on France. Starting in the next 24 hours. There's thousands of people lining up at the ports trying to get back into the UK before they bring the quarantine rule back in. The people who don't make it are supposed to quarantine for another 2 weeks. So, you know, the healthcare workers, I don't know what you do about that. So I come back, you know, you know how tight the shifts are on in the theatres and OR. They come back and they say, we've got to stay at home for another 2 weeks. And anyone who's with you's got to stay at home for another 2 weeks. I know. So it's still crazy.
Well, and I mean, everybody knows what's happening here in the U.S. It's pretty rough, and we're getting ready schools are going back already, and it's, you know, whether you're in or you're out, it's kind of a mess. But it's been a pretty tough time here in the U.S. But well, Monty, we could talk all day about COVID, and we did our COVID series back in the spring, and hopefully we're going to be ramping some of that up again. So stay tuned for some more.
Sadly, it looks like we have to repeat that whole series and go around the globe again, because it's people are in different places all over the globe. You know, our Australian colleagues in Melbourne, for example, it's all kicking off there. Having been quiet before. But anyway, enough of COVID for right now.
Well, I mean, you know, it brings us to the point that right now, Monty, we would be sitting in San Diego in California for the American Association of Nurse Anesthetists 2020 Annual Congress. Last year, we partnered with them to bring 12 amazing conversations from CRNAs around the U.S. About what they are doing, you know, on the front lines, in practice, in research. And we're going to repeat that again this year. We're going to be there. But obviously, it's not happening like all the other conferences that we normally go to and everything else in the world. And so we still decided it was something that we really wanted to do and still have these great conversations.
Mixed feelings about all of that, understandably, because, you know, who wouldn't want to be in San Diego? What a great place.
Exactly. Networking with all of our friends and colleagues.
Who wouldn't want to have the face-to-face experience based on last year in Chicago with the wonderful conversations we had with a broad range of people, really exciting, high-quality stuff. But on the flip side of that is look at all the carbon we're not producing by staying at home and doing it this way. Yeah, so very mixed emotions. But the important thing is we're going to have the very high quality conversations and continue to share that with the world.
We are. So in case you don't know, if you're new to Top Med Talk or not familiar with CRNA, CRNA is a certified registered nurse anesthetist or anesthetist, wherever you are. And I actually am in fact a nurse anesthetist here in the U.S. in Louisville, Kentucky. And we are part of an organization called the American Association of Nurse Anesthetists. So that's kind of a little bit of background about that. And without further ado, I would like to introduce our first guest, who is a fellow CRNA, who is going to be talking to us about a very important topic that she presented for this year's annual Congress, which went all virtual, which will be really cool to visit that. But her presentation was entitled "The Opioid Crisis Gripping America: Pain, Euphoria, and the Creation of a New Surgical Complication. Are your patients safe?" And joining us today is Jennifer Lanzillotta-Rangeley. Jennifer, welcome to Top Med Talk.
Thank you, Desiree. Hello, Monty. How are you?
Hi, Jennifer. I'm good. What a great name. How'd you manage that bundle?
It's fun. I love the hyphenation. That's good.
What?
Yeah, it is, but it's great. Is that Italian, part of that?
Part of it is Italian, yes.
Yeah. So Jennifer, tell us where you're coming to us from.
So I am in Cincinnati, Ohio. I'm a PhD researcher at the University of Cincinnati, right here in Ohio, close to you, right? But my practice is actually about an hour away in a rural community. So I practice at a critical access hospital. It's a CRNA only group. And the area that we're in was one of the original hotspots of the opioid epidemic. So my research is in things that have to do with the opioid epidemic, very pertinent here.
Yeah, absolutely. That's one point that I was going to make. Because I think of where you are, you have a clearer picture of what's happening. And I say that a lot whenever we're talking about opioid addiction, is that, we struggled here in Kentucky as well with, hot spots of opioid use and overdose there for a while. It was really, really bad. So, Jennifer, tell us a little bit about your presentation, what you did for the AANA Annual Congress this year.
So my research originally was to look at how many patients develop prolonged postoperative opioid use after surgery. And then I used the results of that and looked at some other studies that came out about the same time as mine to look at, are our patients safe, and are we doing what we should be doing to protect them when they come in for surgery? It looks like 4 to 6% of our patients who are opioid naive are still using opioids 90 days or more after surgery, which is far beyond the time for healing. And opioid naive is usually defined in these studies as no opioid prescription in the past 12 months.
Wow. Wow.
So that's not a percentage.
Yeah.
So that's over one, if I'm right, there's over 1 in 20 people who hadn't taken an opioid in the previous year after surgery are still on it. Now, are they on it because they need it, or are they hooked on it? Do we know that, Jennifer?
So that's a good question. And are they on it because they had a surgical complication or something like that? And we did exclude patients who had had a repeat surgery or who were in the hospital longer than they should have been, et cetera. There could have been some that needed it. But to have 1 in 20 patients still using opioids more than 90 days begs the question of, why are they still on it? And I would submit that opioids are great for pain control, and they're very necessary for a lot of what we do. But what opioids are really good at is numbing emotional pain. And we also looked at those factors to see what factors do these patients have in common. And what we found is a lot of anxiety, depression, post-traumatic stress disorder, things like that. So, we need to really take a look at our patients and why are they still using these opioids at 90 days.
Do we have any idea about the percentage of patients that come in? I just thought about this, that come into us with high anxiety and depression, like what those rates are? Do we know? Does anybody know that? Jennifer, did you guys look at that?
Well, that's a fantastic question. I would have to go back and look at my cohort to see how many of the patients had anxiety and depression. I don't know. I can only say anecdotally from the charts that I look at what I see on a regular basis. And I definitely see quite a few patients with a diagnosis of anxiety and depression.
Yeah, absolutely. I was just thinking that, so many patients. And you just look at their med list, even if it's something that's not listed as a primary, issue, they definitely are on meds that would be prescribed for that, for sure. And that puts us at higher risk afterwards, right?
And our experience, in the UK, when we've tried to look at this more closely, there are the patients who have a diagnosis of anxiety and depression, which they report to you in your detailed history. And then there's the much bigger cohort of people who have anxiety and or depression, who haven't had it diagnosed. So we have to have a methodology by which we can explore that preoperatively and eke that out to factor it into our evaluation of risk. And we're certainly in our healthcare system, we're not there at the moment. We're not routinely trying to seek out that background of anxiety and depression. We write down the people who say, I've got that diagnosis. We don't explore the people who it's part of everyday life, but they don't have a diagnosis.
Yeah. Jennifer, did you guys look at, obviously, they're the patient factors, and we can talk a little bit more about those. But did you look at prescribing methodology and prescribing habits of us? Because one of the things that we've highlighted in Top Med Talk and through EBPOM, which is evidence-based perioperative medicine, we had a meeting a couple years back where we talked to Matt McAvoy from Vanderbilt, so someone in Tennessee, dealing kind of with this too. And the title of his whole presentation and the whole thing that we did was called "Can We Kick the Habit?" And that's us as providers. So did you guys look at that? And can you speak to that a little bit?
We did look at that. We thought that was very important to look at what we are doing. And what we found is the more opioids a patient receives in that initial post-operative prescription, the higher the chance that they're still using opioids at 90 days. We also found that each prescription refill that the patient receives puts them at higher risk. So we looked at a 0 to 30 day window, and if you had a prescription refill in that 0 to 30 days, you were more likely to get a refill in 60 to 90 days. And when we looked at if you got a refill in 60 to 90 days, you were more likely, again, to get a refill at 90 days or more. So the more opioids we give people, the higher the chance that they're still going to be using post-operatively.
Yeah. Did you look at, we've talked a lot about opioid use on Top Med Talk. And one of the things that became clearer to us is whenever we started talking to different providers and those that were looking into this, is that surgeons would be prescribing a crazy amount of opioids post-operatively. So sending patients home with, 60 to 120, Loratabs or whatever it was. What did you guys find in that?
That's exactly what we found, is when you give those high prescriptions, you're putting your patients at risk. Something that people aren't thinking of is when you give those high prescriptions, you're putting your patients at risk for an overdose. So we've looked at, should they also be going home with a prescription for naloxone?
Oh, wow.
So what some researchers, go ahead, did you want to explore that?
Well, that just kind of blows my mind. Did you just say that if you're sending somebody home with that many prescription or with that many pills, that you send them home with a naloxone as well?
That's correct. That's a new recommendation, that if you're going to send them home with that high of an OME, you're putting your patients at risk for an overdose, or a family member if they have access, if you're not locking them up appropriately. So you should also be sending them home with naloxone.
So my gut reaction, my immediate knee-jerk reaction to that is don't do the first bit. Just as opposed to, saying, let's send a bigger sack and let's send double doses of naloxone because they're twice as risk. What's the challenge in just cutting out the first bit? Is it geography? Is it distance? Is it access to secondary prescriptions?
Well, I think a lot of it is educating our providers.
Yeah.
And another thing that we've started doing in our area in Ohio is we're limiting the number of prescriptions that can be written. So you can only write a prescription for someone who comes in with acute pain for, say, 7 days. Right? And in some instances, it's 3 days. So we're legally limiting the amount that prescribers can prescribe. We also have what we call the ORs in Ohio, where every time a patient in Ohio receives an opioid prescription, they go into a database. That way it eliminates a lot of the doctor shopping so that the next provider can look and see when the last prescription was written. So it doesn't help if they go to Kentucky or Indiana to get a prescription, but it does limit it at least within our state.
Yeah. Well, I know within Kentucky, excuse me, we do that as well. So we've really put a limit on the number of narcotics that can go home with a patient that can be prescribed at a time and refills and that kind of thing. And we do have a database, Casper, I believe is what it's called, that people are registered on. So, I mean, it is accountable. You are accountable for the narcs that you're taking. I'm just blown away that like prescribing naloxone would be an option. Like, are you guys, so I guess let's transition a little bit from, what's going home to what we're doing intraoperatively and as anesthesia providers that we could possibly be reducing the number of narcotics that patients would, one, need, and two, have to have postoperatively. Are you guys working on those types of protocols, or did you look at that?
So yes, we are. That was our next step. And Monty touched on a little bit of what we're doing. We were screening some of our patients. We're educating our patients on what they should take, how to dispose of their opioids so they're not hanging around, how to lock them up and keep it so no one else is using them. But in the hospital, there are a lot of things that we can do. What's really important, and I want to emphasize, is we need to control our patients' pain. We don't want patients having a lot of pain post-operatively for multiple reasons. One, it's unethical. And two, it can lead to chronic pain if you don't manage the acute pain. So, I want to say first and foremost, we need to manage our patients' pain. We don't want to take opioids away and have our patients suffering. I want to be clear about that. But we have seen a lot with the ERAS protocols, with regional anesthesia, with multimodals such as IV Tylenol, Toradol, ketamine. There are other options that we should be exploring. Some people are running, lidocaine drips and doing other things, giving magnesium. So there are a lot of options that researchers are exploring to help control the pain intraoperatively, and then that often decreases the amount of opioids you need postoperatively.
Yeah.
Jennifer, are you seeing any attempts at opioid-free analgesia, which we've had various different reports from various different people to say it's perfectly capable of delivering high quality anesthesia and pain relief for major surgery without touching opioids? Have you seen much of that?
Yes, I know that we are definitely seeing opioid-free anesthesia start to take off. And I've done some opioid-free anesthesia. For instance, I had a patient come in who had just been through the court system and was due to start her Vivitrol shot. And we're like, well, you can't take that before surgery, but let's see what we can do. So we did a complete opioid-free anesthetic for her. And we were able to send her home with no opioid prescription, but with a phone number to call in case she was having pain that could not be controlled. And she went through the surgery beautifully, used no opioids post-op, got her Vivitrol shot, and is doing well in her recovery. So opioid-free anesthesia is definitely a possibility. I don't know that we can use it for every surgery yet because we just aren't there yet with the medications we have. But I think we should be looking and minimizing opioids every chance we have.
Yeah, absolutely. And for our listeners, we may have some people outside of this area. They may not know what Vivitrol is. Can you tell them?
So we call these things medication-assisted therapy. And the idea is if you take a Vivitrol shot, it blocks your opioid receptors so that if you take opioids, you don't get high from them. They won't affect you. Vivitrol is also used for people who have a problem with alcohol. It can be used for both of those. And we also have buprenorphine, which we're using quite a bit in this area, and then methadone. So these medication-assisted therapies help patients get through the cravings, through the early phases of recovery. It's very, very effective. And then as they progress along, some people use these medications for years. Some people stop using them right away, but they're a great adjunct. And in our area, MAT is considered the gold standard for treatment. So it's a combination of the medication and counseling services to help bridge the patient back to a good recovery and a normal life.
Yeah, absolutely. Oh, Monty, I thought you were getting ready to say something.
There's something I want to say close to the wrap that relates to, because often when we get these reports, people say, well, yeah, that's happening in that crazy place where he or she works. Mm-hmm. Whereas, a year ago, the Perioperative Quality Initiative published a set of guidelines about opioids. I was lucky enough to be in that global international round table where they looked at the available literature, and it aligns completely with your experience. That they report in the paper 5.9 to 6.5% of opioid naive individuals go on to be permanent opioid users. So we have to assume it counts for all of us. So if we're giving opioids intraoperatively, we are potentially addicting 1 in 20 people, and that's a really sobering. I took that away from that meeting and from your type of work to say, I must reflect on this every time I pick up a syringe and give it to somebody. 1 in 20, I'm potentially turning into an addict, and that's not a good day at the office. So congratulations on your great work.
Yeah. I think it's so important to continue to have these conversations, and the fact that you're CRNA doing this work and putting this out there. And I mean, this is what we do every day. I mean, we're in the OR, we're the ones administering the drugs. And I think what happens so often, and what I have found through my experiences, in the last several years working with Monty and Top Med Talk and learning more about perioperative medicine and the continuum of care, is that us as anesthesia providers, CRNAs or anesthesiologists, we kind of get wrapped up in just what happens in the OR, right? And so we just don't look at anything past PACU. Our patients are tucked in, they're not having pain, they're very comfortable, and their SATs are fine and their vital signs are fine. Got to go to the next patient. And this is wonderful work that really highlights that what we do impacts the long-term outcomes for our patients. So thank you for that.
Well, thank you very much for having me on. And I appreciate you getting the word out for what we need to do to keep our patients safe.
Yeah.
What next, Jennifer?
That's what I was just going to ask.
You got to change your world and our world. Come on.
Yeah. So what we're doing next is with a Doctor of Nursing practice student that I chaired her project. She developed a perioperative screening tool. And what we did is we took the anxiety, the depression, the PTSD, other factors that we found in the literature, and we have a validated screening tool that we are now using, and we're working on producing a manuscript for that.
Well, when you're ready, let us know, and when you want to get it out there, because we love to share all this great work with people. As soon as you're happy and your institution's happy, if they choose to share it, then please give us a chance to share it.
Yeah, for sure. You can submit those to our abstract portal at ebpom.org. Honestly, I mean, I'm always telling people that it's a great place. It's just the abstract portal. It's not, but just abstract Monty. That's okay, right? It
is, and that we've just opened the one for they're all global events now. For the London one, we had about 8,000 people. We've got about 3,000 or so coming for our so-called Chicago one. We've just opened the Dingle Abstract competition. It's got a nice big prize associated with it as well.
Yeah, that's Ireland, Dingle, Ireland.
Yeah, exactly, which includes free ticket to the next actual conference in Ireland. So,
yeah. There you go. Jennifer, thank you so much for taking the time this morning to discuss with us the opioids and here in the U.S. and the crisis that we've kind of been dealing with, and ways that we can, as anesthesia providers, actually make a difference. So thank you for that, and congratulations on all the work that you're doing. Keep it up, and if there's anything that we can do to help you promote this, let us know.
Thank you so much.
All right. Well, thank you for listening to Top Med Talk. You can always find us on social media. We're on Twitter, LinkedIn, Facebook, and check us out at topmedtalk.com for all the latest coming out. We are here virtually for the American Association of Nurse Anesthetists 2020 Virtual Annual Congress. We have more fantastic conversations coming throughout the next several days. And because this is all virtual and the new platforms and everything we do, it's going to go out over the next days, weeks, months, and year. So be sure to check us out. And Jennifer, have a fabulous day. Thanks for listening.
Top Med Talk. Thanks for downloading Top Med Talk. The time has arrived for you to get yourself your ticket to EBPOM Dingle. That's right. One of the most famous conferences in the perioperative sphere is going ahead. We've taken EBPOM Dingle virtual. The 22nd Current Controversies in Anesthesia and Perioperative Medicine, and SIAA Autumn Congress, will go ahead virtually. Live from Dingle, Ireland, you can attend this incredible conference. Spoken of frequently here on Top Med Talk in hallowed terms, it is of course a place that is known to produce results. EBPOM Dingle. Check out ebpom.org and get yourself online for the Conference of the Year, EBPOM Dingle 2020.